Hormones secreted from the pituitary gland and the adrenal glands influence the function of many tissues and organs. When any of these glands secrete too much or too little of one or more of the hormones, the effects are widespread and may induce psychological as well as physical changes. After this lesson, you will be able to encourage the patient and family to express concerns about a change in endocrine health, explain all disease management related procedures to the patient and family, compare the common clinical manifestations associated with pituitary hypofunction and pituitary hyperfunction, compare the common clinical manifestations associated with hypercortisolism and adrenal insufficiency, and interpret clinical changes and laboratory data to determine effectiveness of therapy for pituitary and adrenal gland alterations. The anterior pituitary gland regulates both metabolism, pigmentation, and sexual development. The disorders associated with the anterior pituitary gland are either hypofunction, known as hypopituitarism or growth retardation, or hyperfunction, known as hyperpituitarism, known as gigantism or acromegaly. Problems arising within the anterior pituitary gland itself is known as primary pituitary dysfunction, and problems that arise in the hypothalamus that change the anterior pituitary function is known as secondary pituitary dysfunction. Causes of pituitary disorders can be related to benign or malignant tumors, which constitute about 10 to 20% of all intracranial tumors. It can also be caused by severe malnutrition or rapid loss of body fat, shock, or severe hypotension. One example would be infarct postpartum. It can also be head trauma, infection, radiation, or AIDS. Hypopituitarism is a deficiency of one or more anterior pituitary hormones. It results in metabolic problems and/or sexual dysfunction. Panhypopituitarism is a decreased production of all anterior pituitary hormones. Most are life-threatening deficiencies, such as ACTH and TSH. There can be a deficiency of gonadotropins. Growth hormone stimulates the liver to produce somatomedins that enhance growth activity. Hypopituitarism is characterized by growth retardation in children, sexual immaturity, and metabolic dysfunction. Insufficient growth hormone will cause stunted growth or dwarfism in children. Insufficient luteinizing hormone will decrease testosterone in males and cause underdeveloped male secondary characteristics. And insufficient follicle-stimulating hormone can cause infertility in women, causing absence of menstrual periods. Okay, continuing to discuss anterior pituitary hypofunction, we will discuss individual deficient hormone and the clinical manifestations. Remember that the growth hormone is responsible for promoting growth through lipolysis, protein anabolism, and insulin antagonism, and the target tissues are bone and soft tissues. A deficiency in growth hormone leads to a decrease in bone density, pathologic fractures, a decrease in muscle strength, and an increase in serum cholesterol levels. The thyroid stimulating hormone, also known as TSH or thyrotropin, stimulates synthesis and release of thyroid hormone, and the target tissue is the thyroid. A deficiency in TSH leads to a decrease in thyroid hormone level, can cause weight gain, may experience intolerance to cold, alopecia of the scalp, menstrual abnormalities, a decreased libido, a slowed cognition, and lethargy. Adrenocorticotropic hormone, ACTH, or corticotropin, stimulates synthesis and release of corticosteroids and adrenocortical growth, and the target tissue is the adrenal cortex. A deficiency in ACTH leads to a decrease in serum cortisol levels, pale, sallow complexion, malaise and lethargy, anorexia, postural hypotension, headache, hypoglycemia, hyponatremia, and a decrease in axillary and pubic hair, most commonly in women. The gonadotropin hormones are luteinizing hormone, LH, or follicle stimulating hormone, FSH. LH stimulates ovulation and progesterone secretion in the ovary and stimulates testosterone secretion in the testes. FSH stimulates estrogen secretion and follicle maturation in the ovary and stimulates spermatogenesis in the testes. Deficiency in LH and/or FSH leads to separate clinical manifestations in men and women. Men will experience a decrease in facial hair, a decrease in ejaculate volume, reduced muscle mass, loss of bone density, a decrease in body hair, a decrease in libido, and impotence. Women can experience amenorrhea, anovulation, low estrogen levels, loss of bone density, a decrease in axillary and pubic hair, and a decrease in libido. Diagnostic tests would include checking pituitary hormone levels, checking the T3 and T4, checking the levels of testosterone and estradiol, providing a stimulation test, or providing x-rays of the skull. You can do a CT, you can do an MRI. Treatment can include a lifelong replacement of deficient hormones, providing androgen therapy for virilization, and gynecomastia can also occur. You may have to do a replacement of estrogens and progesterone. They may also have to receive growth hormone injections. Hyperpituitarism is a hormone oversecretion that occurs with pituitary tumors or hyperplasia. Genetics are considered. It is generally caused due to a pituitary adenoma. Two disorders of hyperpituitarism are acromegaly, which usually occurs after puberty, and gigantism, which occurs before puberty. Okay, let's discuss pituitary hyperfunction. This is an excess of hormones. We will discuss each hormone individually and the associated clinical manifestations. Prolactin, also known as PRL, stimulates breast milk production, and the target tissue is the mammary glands. An excess of PRL leads to hypogonadism, a decrease in gonadotropin levels, galactorrhea, an increase in body fat, and an increase in serum prolactin levels. In men, an increase in LH and FSH leads to hypogonadism or hypergonadism. In pituitary hyperfunction, women will experience a normal LH and FSH level. An excess of the thyroid stimulating hormone leads to an increase in plasma TSH level, an increase in plasma thyroid hormone levels, weight loss, tachycardia and dysrhythmias, heat intolerance. They will experience an increase in GI motility and experience fine tremors. The excess of growth hormone leads to folding of the scalp skin, thickened lips, coarse facial features, increased head size, protrusion of the lower jaw, deepening of the voice, tufting of the fingertips, enlarged hands and feet, joint enlargement and pain, kyphosis and backache, barrel-shaped chest, excessive sweating, hyperglycemia, airway narrowing, sleep apnea, and an enlarged heart, lungs, and liver. An excess of ACTH leads to increased plasma cortisol levels, weight gain, truncal obesity, a moon face, extremity muscle wasting, loss of bone density, hypertension, hyperglycemia, purple striae, acne, thin, easily damaged skin, and hyperpigmentation. For diagnostic testing, we would check hormone levels. Treatment would include non-surgical management or surgical management. Non-surgical management would include drug therapy, radiation, and gamma knife procedure. Surgical management includes to monitor neurologic response, assess for postnasal drip, elevate the head of the bed, assess the nasal drainage, avoid coughing soon after surgery, assess for meningitis, may provide a hormone replacement. You want to teach them to avoid bending, avoid straining at stool, and avoid toothbrushing. They may experience numbness in the area of the incision and have a decreased sense of smell. We may also have to provide vasopressin. This is the end of Part 1 of Module 1 of Alterations of the Endocrine System.